Next up, we have Dr. Rob McCabe. Dr. McCabe is here. He's a partner with Minnesota Gastroenterology, did his training at the University of Cincinnati and his fellowship in gastroenterology at the Barnes Jewish Hospital in St. Louis. He is also one of the authors of the Scenic Investigators discussing and promoting the guidelines for the endoscopic surveillance and management of IBD, so we're lucky to have him. Dr. McCabe.
Okay, thanks, Mark, and thanks to you all again for asking me to participate. So this is a relook at IBD, dysplasia surveillance and management. I don't really have any relevant disclosures. I'm going to briefly talk about risk. Dr. Grahn really covered that in detail, surveillance and dysplasia management. The platform will really be still the 2010 AGA statement and technical review on this topic. Risk, these are the same numbers that Dr. Grahn just showed you. These kind of numbers drove sometimes recommendations for people to have preventative colectomies at 30 years of disease, but studies in recent years don't show risk nearly this high. The problem is that colorectal cancer and IBD is sneaky. It does usually develop from dysplasia, but the typical polyp cancer sequence is often not present, and these cancers can develop surreptitiously and can be hard to see even when there's already cancer present. Dysplasia is probably still our best warning sign that the patient is at higher risk for developing colorectal cancer. So what about surveillance? So the AGA statement in 2010, which I think generally still applies, is that surveillance colonoscopy is important for extensive ulcerative colitis or Crohn's, generally at intervals of 1 to 3 years, starting somewhere between 5 and 10 years after diagnosis. Should be done yearly in patients with primary sclerosing cholangitis, which, as you just heard, are at higher risk, and maybe with other risk factors such as strong family history, previous dysplasia, etc. It was recommended even in 2010 to do careful inspection and sufficient number of, quote, random biopsies. Dye-stain chromoendoscopy, which is a hot topic, was discussed even in 2010. It was acknowledged that dysplasia detection was better with chromo compared to standard colonoscopy. However, the studies back then were done with not the contemporary higher definition scopes we have now. So fast forward, 2015, this references the publication from that Scenic conference, which happened in 2014. Meta-analysis of studies of chromo versus standard white light colonoscopy. You find more dysplasia when you use dye-stain chromo colonoscopy. Some examples. This looks like an innocuous erythematous fold with plain white light colonoscopy. You add some dye stain, and clearly now you have a raised dysplastic lesion. Another example, a vague, slightly raised lesion really pops out when you do dye stain chromo. But is chromoendoscopy with methylene blue or indigo carmine warranted now in an era of high-def colonoscopes? This is an example from one of our patients, quiescent ulcerative colitis. This is done with a high-def modern scope. You see a vague, slightly nodular mucosal pattern. Even with not the greatest dye stain, this is much more visible. The stain settles into that abnormal mucosal pattern, and you can see the extent of this lesion. This lesion was actually removed using submucosal dissection by an advanced endoscopist. The patient's been dysplasia-free for about 3 years now. More examples. On the right, these were pictures taken with high-def colonoscopes. Especially this one, you can see a subtle raised lesion here, which is much more visible using dye-stain colonoscopy. So even with high-def scopes, you can get some advantage with augmentation using dye staining. So this is a later meta-analysis, and the top two groups of studies are chromo versus white light colonoscopy. This is, again, back with older scopes, And you can see that there is a significantly enhanced dysplasia detection when chromo is used. These studies were using more modern high-def scopes. There's a trend towards finding more dysplasia, but not nearly as significant as when compared with using an older scope. So we're able to see better with higher def scopes even without using chromo dye staining. So what about high definition scopes now? Should we or should we not use chromo dye staining? Enthusiasm has certainly dwindled. There's not much chromo done in our group. More dysplasia may be found with dye staining chromo, even in the age of high-def colonoscopes. I still do chromo colonoscopy in higher risk situations, PSC patients who have had random dysplasia discovered. I'll still use chromo with indigo carmine or methylene blue. But regardless of technique, I think the goal is to find visible lesions. If we find visible lesions, they might be endoscopically removable. We might then prevent colectomy for what would have been, quote, randomly detected invisible dysplasia. Maybe we're preventing cancer by finding advanced lesions that might otherwise have been missed. But there are obstacles to this technique. Sometimes the dye is hard to get a hold of. It's expensive. It's not reimbursed. It takes more time. Reimbursement is an issue. It's messy. You really need a near perfect prep, otherwise the dye does not settle into the mucosa. Local endoscopic yield, a lot of us that have done many of these don't really feel like we're finding a lot more lesions. The interval remains unclear. In the UK, for instance, their recommendations are an every 5-year chromo endoscopy for surveillance. That's not really the case here. There may be safety issues with methylene blue, and there has not been enthusiastic thought leader buy-in, especially in the IBD world. Most of this is driven and has come out of the advanced endoscopy community, not so much the IBD community within GI. So what about random biopsies? There was really not a strong consensus that came out of that CNIC conference. There was a strong opinion of some experts that random biopsies should be abandoned, and the opinion of some experts that all dysplasia is visible. And most of us don't believe this, but there are some experts that really think they can see all dysplasia, therefore we don't need to do random biopsies. And this is a pooled analysis of several studies, and the argument for not doing random biopsies is only about 1 or 2 out of every 1,000 random biopsies shows dysplasia. Of patients who have dysplasia detected, 90% are detected with targeted biopsies, only about 10% with random. And of all the biopsies of patients that undergo colonoscopy for surveillance, about 12 to 15% will have dysplasia if targeted biopsies are done, and only about 2% with random biopsies. So the yield is low with random biopsies. So is it really worth taking all those random biopsies when only 1 in 1,000 will find dysplasia? I still do random biopsies. There's still 2% of your patients that may have dysplasia discovered with random biopsies, and you're doing them a service by finding that dysplasia and either intervening or enhancing their surveillance. It does help us assess disease activity. The only real downside is cost. Now, if I have a patient who has ulcerative colitis and has the last 2 previous colonoscopies have been normal with normal biopsies, and they literally have a normal colonoscopy, maybe you can make a case for not doing random biopsies there. But if there's anything the least bit abnormal or any disease activity, et cetera, I think my thought is generally the default should be to do still random biopsies. The other thought is that over the years, how many biopsies that went into that random biopsy jar were really random? You know, we're going through the colon, we're taking random biopsies. There's a spot that looks a little bit funny. That's what we grab, and we put it in the random jar. It's not a distinct enough lesion that we biopsy it separately and identify it separately, but it looks a little funny, it looks a little different. That goes into the random jar. It's called a random biopsy, but is it really random? So I still advocate doing random biopsies. So what about dysplasia management? So back in 2010, the AGA position statement reported these descriptors and recommendations. For a non-adenoma like DOM, and we're going to come back to DOM, a colectomy is recommended. For an adenoma like polypoid lesion, so your basic polyp, you take it out, you do a polypectomy. For flat, random, or invisible high-grade dysplasia, colectomy is recommended. For flat, random, invisible, low-grade dysplasia, kind of a question mark there. So fast forward again to the CNIC conference. The terminology was reviewed, and a revamped terminology was recommended, and this is based on the Paris polyp classification, and that dysplasia in IBD should be described as visible or invisible, invisible being that dysplasia found on random biopsies. And then visible is split up into polypoid, non-polypoid, other descriptors such as ulcerated, and whether the border is distinct or indistinct. No more DOM. I grew up learning that DOM is a dysplastic lesion in an IBD colon that looks peculiar or funny, and that meant they needed a colectomy. But it probably doesn't matter whether it looks peculiar or funny. It probably matters is whether it can be removed with the colonoscope. So this conference recommended dropping the DOM descriptor. So what do we do with visible dysplasia? If we see visible dysplasia and it's not endoscopically removable, if it's too diffuse, if there's indistinct edges, then the default option is a colectomy. If it's endoscopically removable, and really whether it's high-grade or low-grade, if it's endoscopically removable, you can remove it. We remove high-grade dysplastic polyps all the time. Then endoscopic resection and monitor closely. The aggressiveness of monitoring probably depending on a number of factors, including disease activity. Important in this is the availability of advanced endoscopists skilled in endoscopic mucosal resection and submucosal dissection. These people can remove lesions such as that one I showed a few slides back. And I encourage you, Dr. Sutikno has a very nice review of the techniques used to remove these lesions. What about invisible dysplasia? Low grade, unifocal, no other real risk factors. Most people, I think, would agree with just monitoring that, maybe with chromo exam, but just probably enhanced surveillance. I don't think many people are recommending colectomy for isolated low-grade dysplasia. If it's multifocal, if there's active disease, PSC, a family history, previous dysplasia, a tubular colon, plus minus not finding a resectable lesion on a subsequent exam, then a colectomy needs to be considered. High-grade dysplasia, there's probably a really high risk of asynchronous colorectal cancer. Colectomy is certainly the default option. It's up to you all how your surgery changes if there's rectal high-grade dysplasia. Some pundits, some advanced colonoscopists would argue that it would be reasonable to do one chromo exam to see if you can find the high-grade dysplasia. And if you find the lesion that is the high-grade dysplasia and you remove it, that maybe you could avoid a colectomy. I think that's a little risky, and still the colectomy probably ought to be the default option. If there's active disease, no lesion found on chromo, then a colectomy. Risk reduction, Dr. Grahn talked about this. I think our job as gastroenterologists is optimal medical therapy. Try and get this disease into a deep remission so that the inflammation isn't driving that cancer risk. In summary, surveillance, review literature, look at the society guidelines. You can increase the interval if there's a deep remission. Consider chromo for higher risk settings, review how-to videos, play around with narrowband imaging. But most importantly, a very careful inspection, slow withdrawal, allow extra time. Random biopsies are okay. If it looks suspicious, biopsy it. I found 2 cancers on surveillance biopsies, random biopsies in the last 5 years, probably because I biopsied something that just looked a little bit different. Especially refractory rectal inflammation, watch closely. Dysplasia management I discussed, very individualized. Patient, pathology, surgery, advanced endoscopy involvement is key. So, thanks for your time. Well, I think that's where the discussion with all the players comes in, and whether it's Crohn's and whether there's clearly just segmental disease, and as opposed to ulcerative colitis. I think still the default would be a colectomy for ulcerative colitis. If it's segmental disease with Crohn's, and there's clearly spared areas of the colon, then a segmental resection, I think, would be part of the discussion. But I see where you're coming from on that, with the whole idea of field defect, et cetera.
So my sense in the community, too, is that since those guidelines came out, I'm seeing less and less of my patients that I may see for anal rectal disease or something, and I'm just reviewing their last colonoscopy, who are getting fewer of the random biopsies. Is that your sense as well? And I mean, we're also seeing, I've been in practice about 7 years. 7 years ago, I might see a couple cases a year of a patient for an opinion about a random low-grade or high-grade dysplasia found on biopsy. And I can't honestly think of that in the last couple of years. Maybe that's just, the word's out that, Dorsey Osborne, but, I just wanted to get your thought, too.
Well, I think we're not sending people to you for an opinion on a low-grade, a single low-grade dysplasia biopsy.
Yeah. But do you think fewer of the IBD docs are doing the random biopsies, or is that staying constant?
I think they're still doing random biopsies.
Okay.
Yeah.
What's the referral pattern, or if there is any, for low-grade dysplasia in a patient with a J pouch at the cuff? What do you guys typically repeat the question?
Low-grade dysplasia in a rectal cuff in a patient with a pouch. I have not run into that, but that would go right back to you for a discussion.
So you would do a surgical?
For a low-grade dysplasia in a cuff, I would think, that's kind of a unusual situation. So, I would think I would get your opinion on that. Yeah. I would imagine it would be just followed, but yeah.
Thank you, Dr. McCabe.
Good. Thank you.